If you are as they said, in North America, you are on the teller machine and you are trying to take some money, and somebody came to you, oh, your money, come on. And what's this? This is a knife. Okay? The whole thing is, you go like this, so you bend his wrist. The minute you bend his wrist, the grip is off. Why? Because when Allah subhanahu wa ta'ala made it in a beautiful way, our grip here, whenever we make a grip, subconsciously, we make it with the flexors or the extensors, the grip, flexors. But subconsciously, alhamdulillah, our extensors go into contraction as well. Why? Because
for the joints.
to stabilize. Not, believe me, not it is starting by S. To stretch the muscles. When we stretch if you stretch any muscle, what will happen? The force of contraction will increase. They don't know why. If this muscle is going like this, the length is less. It will be redundant. So the force of the grip went down 8 times. Even somebody said 16. You go like this, the grip goes up 16 times. If you are playing boxing, have you ever seen Muhammad Ali? You know Muhammad Ali?
Yes.
Or have you ever seen him in doing a knockout? You have to go backward and pop like this. Why? To stretch. Pectoralis major comes like this. Have you ever seen Muhammad Ali? No. Even Muhammad Ali, if he knocks out he will not do this to his wife because it's not painful. Are you following me? So you have to stretch and kill. A cat. What does a cat do? A cat, the height of a cat is nearly 7-8 inches, the height of a cat. But a cat can actually jump her height 10 times. How? She has, like us, muscles of the leg. What does she do? What does she do? يا ريت كنت أقدر أطلع على الترابيزة but ما تحكوش. What does she do? Look at this. What are the muscles that will make the cat go up? Her gastrocnemius and the muscle here. So what does she do? She will jump like this? No, she will go back to stretch them and then go up. You understand? ما فيش كات نو يعني الكات مش غبية عاوزة تنط بتروح راجعة لورا وطالعة. صح ولا لا؟ عمركم شفت كات شالت نفسها كده؟ حمارة؟ لا مش حمارة مش غبية. Are you following me in English or Arabic? This what we call now. If a patient sits in front of you in your clinic and you want to do the reflex, what happens when you leave his leg like this? You stretch his muscle. You do what? And this will help you make the reflex. Thank you. معلش كسرنا الألم. For a cat to stretch before contraction, for me to stretch before knocking out, for me to stretch the leg of the patient before I tap it. This is called not a normal contraction. It's called myotatic contraction. What's it called? Myotatic contraction. Even for me to remember it, because I have a cat myself. I remove the T, I put C, and I say myotatic to remember it. So it is myotatic contraction. So what's myotatic contraction? Contraction after stretch. This is why this guy, look at him now. The flexors here are contracting. Watch me, watch. In order to tighten the grip of the hand on something, the extensors of the forearm should contract to cause the stretch of the flexors. So this is the term used by the physicists and the people who are interested in describing the energy of the muscle. They said the residual force of the muscle increase after stretch 8 times. This how I can actually take the knife from the person who is attacking me by just stopping the stretch. What does this have to do with our elbow? I'm not stupid. I got it for a reason. Here we are. In order for a tennis player to have a good grip, always his extensors are and flexors, but the extensors are going mad. So what will happen if he is gripping like this for 4 hours, 5 hours? What will happen? The extensors, where are the extensors having common origin? Lateral or medial epicondyle? Lateral epicondyle. For this reason, here is the lateral epicondyle. Here is the lateral epicondyle in this area. Here is the lateral epicondyle in this area. Coming off it, the radial collateral ligament with its 2 here, 2 elements, and the third. Here is the common extensor tendon. Above it, not below it. Above it, not below it. Above it, not below it. It means that I'm going to ask it. The tendon, the common flexor tendon, extensor tendon is above the radial collateral. Common sense. And what happens to Federer after 4 or 5 hours playing tennis? There will be pain. Is the pain at the attachment of the radial collateral ligament?
No.
Or above it?
Above.
Beautiful. Beautiful. So the doctor is going to treat, he is going to go higher than this ligament and inject cortisone or inject whatever. Is the ligament stretched? The radial collateral ligament stretched? No. What was stretched? The muscles. And they caused what they say minute avulsions at the site where they are attached here. Above the radial collateral ligament. Radial collateral ligament is formed of radial collateral part, annular ligament, and lateral ulnar collateral ligament. What a big name. Lateral ulnar collateral ligament. This should be lateral radial collateral ligament. Yes, it should be. Missing here is L. Lateral radial, the whole ligament is radial collateral ligament. So radial collateral ligament, are you following me? So you correct this. Radial collateral ligament is the whole 3. This should be LRCL. And this is LUCL. And this is annular ligament, the ligament which is having the articulating surface for the head of the radius. Please do not confuse it with ulnar collateral ligament, which is like radial collateral ligament on the other side. Here you can remember it by one thing. I have a point, and this ligament, the lateral radial collateral ligament and the lateral ulnar collateral, they diverge anteriorly. They diverge anteriorly, meaning in the anterior direction. But this is here in the flexion. But in the anatomical position, they diverge inferiorly. La ilaha illallah. Okay, so they diverge in this, for us to remember, and in this flex, they diverge anteriorly, but anatomically, they are diverging inferiorly to be attached to the annular ligament. But this will help us to say diverge anteriorly, because anterior and annular are starting by AN, and this will help us. I thought that many textbooks are writing ANULAR. This is garbage. It is double N. Okay? Very good. I care about minute things, but they actually, what is this guy doing? He is playing something different. And there is what we call golfer's elbow, which is actually counterpart of the tennis elbow. And it is one of the causes or differential diagnosis of medial elbow pain, ulnar collateral ligament of the elbow. So we were here speaking about radial collateral ligament. Now we are speaking about ulnar collateral ligament. What happens? This guy is holding a weight here like this, and he should make this go, imagine, sometimes 150 kilometers an hour, and he goes like this. You see this? What it did to my arm? He should, and they are trained to make this arm steady while this go back. Are you following? To spring. Are you following me? So here they build the shoulders so to control this. So, but when this spring with this weight like this, he is actually stretching this. You follow? Stretch a lot. And they do this thousands of times because they are professionals. And they take palmaris longus and they drill in the bones between humerus and the ulna, and they put this new ligament, and even they say now we are better, and even they are counting for us a faster speed for our ball. Very, very strange. Now we know the difference between, there are two differences here. One is making a grip for 4 hours. This is Federer, making a grip. For 4 hours he is gripping like this. Like this. And the other is, for 4 hours he is stretching here like this. A weight, there is a weight. Are you following? There is a difference. So, something with a weight like this, is it on the medial or the lateral? Medial. Something with gripping like this on the lateral. If you understand this, this is my lecture. To make the differentiation to understand. To understand. Science, it's all over. Books, copying from here and there. Books, sometimes dumb, sometimes smart, but we have to be smart. Not sometimes smart, sometimes... No, we have to be always smart. That's great. So, here is the ligament, and again, 3 parts. But this ligament, if you compare it to the other ligament, in the flex position, is it diverging posteriorly or anteriorly? And the other one is diverging where? Exactly. And in anatomical position, this is diverging upwards and the other one is diverging downwards. Open your mind. Open your mind, please. These very small observations mean a lot. They make things easy, because when you put one observation on the other, on the third, on the fourth, you make the precise picture. The precise picture. Medicine for observant people. Like you. Of course, like me as well. Okay? Did we get that? Especially me. Okay. I'm sorry. Anterior oblique band resist valgus stress. When I do this, شايفين ادي الارم وادي الفور. When I do this, this is valgus stress. valgus يعني دي كده والفور arm بتاعي يروح كده. فاهمين ازاي؟ So this is called what? Valgus stress. If this is my right arm and this is going like this, the medial ligament is stressed. We call it valgus stress. And the most important part of the medial collateral ligament is the anterior oblique band. This is nothing, and this is nothing. So this is the most important band. This is here where they put palmaris longus tendon, and they drill and they make an H-shaped thing here, an H-shaped figure, to replace or reconstruct the medial collateral ligament. Here is the stress. Look at that, and he looks angry, like a donkey, and he is going actually to... Can you see that? Really, he's a beefy thing. And now we put here that 8th thing. That the drill was done, and this is the new, and this is the man who had it in the first history of humanity, Tommy John. And as he said, he played faster after that. Oblique band, related to which nerve? Ulnar nerve. What do we call this? What do we call this area? Cubital canal. For the ulnar nerve has a cubital here, cubital fossa, cubital canal, call it whatever, but it's the cubital canal here in this area. Notice the oblique band. Observe. The oblique band is formed of 2 kind of fibers. Some of them are going downwards. I'm speaking now anatomically. Okay, downwards anatomically. And this is going transversely. But transversely, when we put this in anatomical position, it will be vertical. Did we get that? Thank you. Which of these is very important in resisting valgus stress? The anterior oblique. If I put this down in anatomical position, this is still posterior, and this will be inferior posterior. Ya Rab. Ulnar collateral ligament, different from LUCL. You remember the LUCL? Lateral ulnar collateral ligament, which is part of the lateral collateral ligament. Very good. Who is going to develop tennis elbow? This or this?
No, the person on the right.
The one who is using what? The hammer. Thank you so much. Thank you so much. Bersey versus fat pads. We have something very, very nice in the elbow and unique. We have fossa like this. And the anteriorly and a deeper one posteriorly. During flexion, where is the elbow? Where is the olecranon? Is it inside the fossa or outside the fossa? Outside the fossa. The fossa is always occupied. We say it in Arabic, راح القط يلعب الفار. صح ولا لا? If the olecranon is out, immediately this pad of fat will fill the olecranon fossa. Are you following? So the olecranon fossa, then if I do this extension, the olecranon will go and push this fat out. Are you following? So this fat is present in the fossa during flexion. On extension, the olecranon will push it away and will occupy the fossa. Very nice. Why? To dampen the pressure from here on there during extension. And this pad of fat is uniquely put between the fibrous part and the synovial part of the capsule. So these fat pads are intracapsular. Intracapsular. لما بقى أرزع سؤال في الامتحان, when I put a question in the exam and I say the pad of fat is intra-articular, ده كلام صح? No, intra-articular meaning that it's in the cavity. When I said it is intracapsular, صح? Extracapsular, صح? No, what's going to happen here? I see bursa. Bursa are extracapsular. Bursa, they don't dampen another function. They don't dampen the pressure, or they don't dampen the shock between two articulating parts. They are here to lubricate between moving soft tissue. There is here a bursa called subcutaneous, and this just for the movement of the skin over the olecranon. soft tissue. الاولكرينون soft tissue لا, عليه بيبقى موجود fascia, والسكن فيه fascia. Between the fascia of the olecranon and the fascia of the skin, there is a bursa. Between the tendon and the capsule, between tendon and there is a bursa. Which is deeper, this bursa or this bursa? This bursa. And we call it subtendinous bursa, but this one is subcutaneous bursa. There is a bursa between the tendons, the uniting tendons of triceps, and we call it intra tendinous. ليه كابسولار يا حبيبي؟ ليه كابسولار يابا؟ أنا بريء، والله بريء، والله بريء يا رب. So there is intratendinous bursa, and all the pad of fat are intracapsular. This is superficial, and this is deep. Bursy, subtendinous, intratendinous, subcutaneous. حتى كان في صاحبي زمان كان يقول عشان نفتكرها هنقول دي سوسو ودي ان ماشي sub and sub بلا عرف. And then here is a bursa which is getting inflamed and we'll call it olecranon bursitis. How many times I removed these and they come out like a walnut, very, very hard. Some people prefer aspirating them, but they come back. Remove it, and very easy to remove. Very, very easy to remove. I wish I got the film, but there was no time for me to bring the film. Fat pads between fibrous and synovial parts of the capsule, so they are intracapsular. There is anterior and posterior, they dampen the shock between the articulating. مش كده وبس. They have a very ايه يا سيدي القرف ده. Are we following؟ خلاص متابعين؟ Look at this. This is normal. This is abnormal. شوفوا لي ايه الديفرنس هنا بسرعة. بسرعة. إذا ما عجبتوش ده هنشوف حاجة تانية. هنشوفه هو يس قول. قول. تعال اطلع ووريني الراديالس والحاجات دي وريني بسرعة الله يخليك ما فيش وقت. يلا بسرعة. في ايه اللي في الهيد؟ ماشي وايه تاني؟ الهيد التانية مش طبيعية. والله لا تسقفوا له والمصحف لا تسقفوا له. والله بص اسمك ايه؟ محمد. بص يا محمد صح. وزيادة على كده محمد بص لما حصل كسر هنا there is وده الكسر ده مش سهل ان يشوفوا واحد سهران طول الليل في emergency and خلاص but there is effusion here and the pad of fat اللي درسناها مش بس نعرف ان هي intracapsular وننام عليها لا ده ليها application من العز زي الكورانين بيرسا دي ليها application وapplication خطير. الابليكيشن ايه هو؟ لو تلاحظوا هنا شايفين هنا دي مسوده شويه ودي مسوده حبتين. شايفين السواد اللي هنا ده؟ مش شايفينه هنشوفه في اكبر ويبان في هنشوفه هجيب لكم واحد تاني دلوقتي. اقعد. الفكره هنا الفكره if there is effusion in this area because of this fracture, what will happen to the bed of fat? It will be what? Pushed up. الفات is it dark or is it black? Sorry, is it white or black? Black. This is black and this is black. There was this is black. You see this black? أنا هنزل هوريكم الإكس راي اللي هو اللي كبرته. يمكن إن شاء الله يوضح أكتر. حاجة بنسميها السادل ساين. شايفين ده؟ شايفين الحتة البلاك دي؟ إذا مش شايفينها ما تزعلوش. شايفين البلاك ده؟ شايفين البلاك ده؟ شايفين ده؟ This black is the pad of fat anterior. Here we cannot see the posterior. Now I can see that the posterior is a bit pushed. Don't worry, we'll go to another one. Look at this. شايفين ده؟ شايفين ده؟ This is darker than around. شايفين ده؟ Can you see this? This was originally here, but because of the effusion it is out. This was filling all this. يعني شايفين أهو. This is it. All of it. All the pad of fat is here. It needs trained eyes, but now because of the effusion it went up. It was pushed up. نشوف واحد كمان. أهو. آدي هو ده. ده الباد of fat. Posteriorly, normally you don't see it. But when there is effusion, it is pushed away, and you can see it here, pushed away. You can see part of it even here. Are you following? You can see this here, and we call this because it looks like the sail of the sail of a ship, we call it the sail sign. Anyway, this needs a bit of training, but just to tell you how we don't teach for just teaching and, oh, listen, this is that and that, oh, goodbye, I'm a doctor, you are a doctor. No. We learn, we teach for life, to use something and understand something and deepen our insight. Are you following? Okay. يلا واحد يديني الأسماء. يلا لو في observation. يلا اديني الأسماء. استناني. دي اسمها ايه؟ subtendinous ولا subcutaneous؟ subtendinous ولا subcutaneous؟ subtendinous. طب ودي intracapsular ولا intratendinous؟ طب ودي subcutaneous ولا subtendinous؟ Are you following? ماشي. اوكي. عاوزين نبقى عندنا observation. بصوا بقى حكايه اللي هو supracondylar fraction. supra what؟ condylar. معلش الجماعه اللي يقولوا سبكوندايلر وايطاليانو ده بلاش الايطاليانو ده اللي هو كاميليانو ايطاليانو كوندايلارو لا بلاش. subcondylar. What's it called؟ Yes, subcondylar. اوكي مش عاوز حد يضحك عليك. الاجانب يضحكوا عليك ليه؟ مش احسن منك ولا احسن مني ولا احسن من حد ولا احنا احسن منهم، كلنا زي بعض. So subcondylar fracture. Why does the subcondylar fracture happens in this place? And it happens always in kids. Because, look with me here. Can you see this constriction of the bone?
Yes.
Over the capitulum and over the trochlea? Can you see this constriction?
Yes.
And this what happens. Look. When there is force, it will push it easily. This is the mechanism of the fracture. And we call this distal fragment. And we call this proximal fragment. And depending on the position of, when we speak about position, and we say there is a posterior or anterior this is posterior or anterior? Posterior. If the distal fragment is anteriorly, or it is in front of the humerus, we call it anterior. Are you following? So we call the fracture according to the position of the distal fragment. Very good. Very good. Did you read that? Read it carefully. I'm not going to speak it. Read it. You agree? Read this as well. This is beautiful. Read this carefully. Read this carefully. This is very beautiful. According to the experience, which is between brackets research, if the fracture has caused vascular injury, most probably there will be an accompanying nerve injury. ده فايدة الريسيرش. يجوا كل شوية هم مش عبط الأجانب ولا احنا عبط، ما حدش عبيط. يجي يقول لك ايه تعالى بقى نبص 5 سنين فاتوا كنا بنعالج ازاي السوبراكونديلار فراكشر. ماشي تعالى نشوف. يعدوا البيشنتس، بعد ما يعدوا البيشنتس طيب حصل ايه؟ في ناس والله كان البريكال ارتري اتقطع وفي ناس ما اتقطعش. طب قسمهم. احنا بقى يقول لك لا ده الاجانب دول اغبياء. الاجانب مش اغبياء. ده قسمها كده ولاحظ حاجه. لاحظ ان الناس اللي هي البريكال ارتري بتاعها اتضرب، النيرفز اتضربت. لابد واحد منهم بيقطع. Are you following me in English or Arabic? Do you understand my? Okay, I'll speak in English now. Research, we go backwards. We see how many cases we actually treated of supracondylar fractures, and we classify them. Those who got brachial artery damage and those who didn't. We found that those with brachial artery damage, they had at least one nerve damaged. Allah. So how this will help me? How this will help me now? Am I wasting my time just to make a paper and write my name? This research done. No. It's done for one reason. When I receive a kid with supracondylar fracture and brachial artery injury, I should know that there is nerve, and I should do open reduction. Open reduction. While the other one, I should not, because it will be a waste of. شايفين؟ ده تدريس الاناتومي. الاناتومي يتدرس بالطرقات، مش يتدرس لا يمكن. Open reduction. Open reduction. So if I have a patient with brachial artery, I have to do open reduction. You agree? Open reduction means I shall make an incision, go to the bones, try to bring them together, and look for any nerve, the nerve which is suggested to be injured, and I should repair it.
But it will not be repaired.
It will be repaired. Did we get that? But if I see a patient with no brachial artery, do I open?
No.
Treat conservatively. But if it happened and the luck didn't work, open. You following or not? بصوا بقى. ده طبعا supracondylar fracture. You agree? أنا عشان ما أظلمكش, it's very difficult to guess it. But this is not ulnar nerve. Ulnar nerve should be very, very medial, يعني to one side. يعني الألنر لابد يكون one side هنا أو هنا. بس ممكن تقول ده median أو ممكن تقول this could be median or could be الله ينور عليك. الله ينور. Could be medial, could be very good. Median. What's immediately beside it? Artery. Can you see an artery beside it? شايف artery beside the? So this should be what? أيوة كده ريحوا الدنيا. أي يا رب. ليه يا رب? And this what happened to this patient. So what's affected?
Extensive.
دي الحته دي مش هتلاقوها في الكتب بتاعتي انا. في الكتب بتاعتي اللي كتبتها في مونتريال. كل اللي طبعته في مونتريال دي من حته من مونتريال بقى. خدوها حته حلوه. انا هسيبها لكم وتقروها. قول اللي تقوله. Are you following this? The nerve runs between the floor of the and the lateral boundary muscles of the cubital fossa. ادي الكوبيتال fossa. شايفينها؟ This is what? The floor. And this is lateral boundary. Brachioradialis minus brachialis equals radialis. So between brachialis and brachioradialis, I should find radial nerve. So when I am opening the cubital fossa of a patient, get brachialis, get brachioradialis, and in the furrow in between, you open, you'll find the radial nerve. مش هقول لكم انا اشتغلت كتير واشتغلت مع جراح. مره جالنا واحد جان شوت في حته في انجلترا اسمها جولستون وفتح. طيب يا سيدي ده الريست في ضرب يابا افتح عشان بليز جو تو ذا راديال نير. انت فاهم فين هو؟ عمال يدور بقى في الفات ومش عارف. انا ما عملتهاش قبل كده بس هدور وهجيب. يخرب بيتك اذا ما كنتش عارف فين هو مش هتجيبه. إذا ما كنتش عارف إن بريكيوريديالس ماينس بريكيالس إيكوالز راديالس مش هتجيبه. ما تضيعش وقت. Are you following? This is anatomy. مش شوربة. Okay? Following? So when you are looking for something, you have to know where it is. Where is radial nerve? تتحط في سؤال ولا ما تتحطش في سؤال؟ Fair ولا مش fair? Differentiating good from bad or not? You have to learn. You have to learn. Radial tunnel just make us remember the cubital tunnel, which is here, where the ulnar is. Supracondylar fracture بيفكرنا بحاجة اسمها carrying angle. It reminds us of the carrying angle because when I am making open reduction يعني فتحت كجراح وعاوز بقى ألم العظم تاني. The fracture now I am going to repair the fracture. I opened. I have to make sure that the carrying angle is there. You know the carrying angle. But are you following? You see the angle? This angle helps people to live and earn their life. If our arm, and this we call this cubitus valgus, if our arm cubitus varus, يبقى هنتحرك كده وهيبقى حياتنا بؤس. Are you following? مين اللي لابد انتوا فاهمين ولا مش فاهمين؟ If the forearm is like this, more and more it will help ladies. Ladies بيربونا بيشيلوا العيال. This is why their carrying angle, subhanallah, جل جلاله, made the carrying angle in ladies more than men. You understand?
Yes.
Carrying angle is the angle between the forearm and the arm axis. This is the axis of the arm, this is the axis of the forearm, and this is the carrying angle. We call it, if it is going like this, we call it valgus. So there is normal valgus in our arm. Normal what? Valgus. لو زاد عن حده الفالجاس ده وانا بلعب بيسبول خلاص بقى torn. Okay? Are you following? So there is normal valgus. Is it valgus or varus? And it is 5 to 15 أو بنقيسها ساعات من هنا. So it is 165 to 1. It is in average 13.6 female, 6.7 males. Who is larger, male or female? A concept of prime importance to be considered while managing elbow fractures. I am opening, then I should put the arm in valgus, not varus, neither straight. Are you following? لما يتحط سؤال زي ده في الإكزام, fair or not fair? مفيد ولا مش مفيد? Okay. This location. We name this location according to where the elbow will be. The olecranon will be. If the olecranon will be posterior to the humerus, it is posterior. Anterior, anterior. Posterolateral, posterolateral. Are you following? The commonest is posterolateral. with an injury like this, would you expect neurovascular damage? Of course. Of course. People treat this sometimes with just closed reduction. This is one of the things I don't agree with orthopedicians about. This cannot be done with closed reduction. Why? This is my idea. أنا بعلم عقول، مش بعلم ناس خدوا الكتاب واقروا الكتاب وخلي بالك. طب ما جيش خلاص اقروا الكتاب والسلام عليكم. لما هنلتزم بلاش تفكير. Are you following? Why? This is a very secure joint. Secure because of its shape. There is a spool, bakara, and there is a groove. So, to have it like this, it means that there was immense power. If I have immense power to do this, there should be a fracture with this. Number one. Number two, to have this shape like this in a very small area, it means that I'm pressing on either nerves or vessels. Okay? This is my opinion. And in the opinion of orthopedicians, they are saying, no, we'll close it. If we need, we'll go into open. Okay? Are you following me? Very good. في النساء والولادة. أنا اشتغلت نساء والولادة 6-7 سنين لأنه كنت نفسي أكون pelvic surgeon. كان نفسي أكون pelvic surgeon، ما حصلش. مش لأني كنت خايف، لا، لأن الناس قالوا لا أنت شاطر في دي، هتدرس دي 20 سنة، وحصل زي ما قالوا، درست دي 20 سنة زي ما هم قالوا. كنت مش متخيل لكن حصل. كان حاجة في النساء والولادة يجي لما يبقى في، عارفين الشولدر جوينت، وشفنا اللي هو الباراليسيس بتاع دوشين، لما يبقى في بيبي كبير ماكروسوميا، في واحد طلياني اسمه زيفاريلي، قال لك زيفاريلي قال لك ايه، رجع البيبي تاني لو في شولدر. ما هو كلام حشيش، حشيش تقيل. Are you following me؟ ما اقدرش اقول ده بالانجليزي. May Allah destroy their house. ما يخرب بيت كده. Okay, did we get that? Okay. Are you following? Okay. الله العظيم. بصوا بقى. most of the fractures happens supracondylar fractures happens, they are commoner in children, not in adults. This is why I have to know cryo, the cryptognomonic. Why? Because if I see here ossification center, I might say, oh, this is the part of the fracture which is here. Are you following me? Because ossification centers look like fragments of a fracture. You follow? But if I know, for instance, trochlea 7, and it means that at the age of 7, I will have 4 ossification centers. Are you following me? Are you following or not? Wallahi, are you following? So at the age of 7, I will have 4 ossification centers. The capitulum, ده الاسم الجديد اللي هم حاطينه، الكابيتيلم ده عشان الناس اللي عندها تقل في لسانها ينطقوه، وده دلالة على الغباوة. Okay? Capitulum is the better name, but capitellum ده للناس اللي لسانها تقيل. Okay? تقل اللسان غباوة. أنا بقول غباوة. اللي ما يعرفش ينطق حلو غبي. سوري حقيقة سبحان الله. الله ده ربنا قال بلسان عربي مبين. فلما خاطب وقال بلسان عربي مبين النبي صلى الله عليه وسلم، لأن لسانه أحلى لسان ومبين، لأنه هو من أزكى الناس وهو أزكى واحد وأطهر واحد صلى الله عليه وسلم، لابد يكون مبين. فالعكس بتاعه يبقى كابيتيلم. اوكي راديال هيد. هذا مفقوع. internal epicondyle trochlea. Are you following؟ يبقى دلوقتي لو واحد عنده بس عنده 5 سنين 5 years, and instead of finding 5 fragments, capitulum, radial head, capitulum, radial head, and internal, and instead of finding 3, I found 4 after he fell. This means he has a fracture. Did you understand this? Did you enjoy it? Thank you so much.